All right, everyone. Thanks for tuning in. We are live. I'm Dr. Ryan Bear of Flash Momentum. I'm here with Dr. Brady, who is the gentleman in the Flash shirt, and also Dr. Alan Harris, who's joining us from Beatty Harris Sports Medicine today. Recently opened last week, right, Dr. Harris?
That's correct.
Okay. And to tell you a little more about all of us, Dr. Brady and I are sports PTs at Flash Momentum. We've been open for 8 years, working with runners, golfers, tennis players, anyone who's really active is our specialty. And all of you watching today are golfers or tennis players, and our topic is the sciatica. So the sciatica solution. We're going to be going through things that you can do for sciatica, and also insights on what could be going on and when you should see a sports med doc. So Dr. Harris is a graduate of Penn State University. He was a Division I gymnast there for 4 years and a national champion. I'm not sure if that was individual or team. Could you let us know a little more about that, Dr. Harris?
Sure. Yes, I did gymnastics my entire life, but yep, 4 years at Penn State. It was a team national championship.
Okay.
Then I was captain my senior year. So yeah.
Okay. Very good. And he is a board certified sports medicine physician who completed his residency and fellowship at Crozier Keystone Health System. Also went to the Philadelphia College of Osteopathic Medicine to earn his medical degree, and is currently the team physician for the Philadelphia Union, Bethlehem Steel, University of Delaware Athletics, Marple Newtown High School, and Interboro High School. Maybe some of those in the past, but I know at some point or another, all of those different school athletics. So we're really excited to have him here joining us today, and we have a lot to go through. So we're going to get right into it. Dr. Brady, I know you wanted to start off with a little bit more about what sciatica is and you know what they could be experiencing in terms of pain, right? Let me unmute you.
Unmute. We good?
Yeah, there you go. We can hear you.
Dr. Harris, it's great to finally meet you. I know we talked a lot about you at Flash over the last couple of weeks, but just for simplicity purposes, I'll just talk a little bit about sciatica, kind of more of the prevalence. It's in my opinion, and I think the statistics show this as well, it's by far the most prevalent muscular-skeletal disease that people come to seek medicine for, whether it's a PT or a sports med doc, a DO. I believe that the current research along low back pain, at least in the PT profession, is those who have low back pain, only about 7% of those actually reach a PT office, which I think is pretty fascinating. For simplicity's sake, I'll talk about sciatica with radiculopathy signs, in the presence of hard neurosigns, changes in sensory motor function, as well as reflexes. We do see that a little bit in our clinic. Those who have hard neurosigns, sensation, muscular strength deficits, reflex, abnormalities, those tend to, from what we see, they can respond well to rehab, but a lot of times the progress is a little bit slower. Then we can also have more of the sciatic or radiculopathy symptoms without hard neurosigns, which we see a lot as well. Definitely, I don't have any stats to talk on the prevalence, but we see this more without kind of the hard neuro findings, and especially those for the hard neuro findings. When we see those in the clinic, if we can't change those quickly, when we're always doing tests, retesting with our interventions, we know if we can't change hard neuroscience and if they're getting worse, then we want to refer out to a guy like Dr. Harris for sure. Yeah, Dr. Harris, do you have any thoughts and on kind of how you view low back pain in society and kind of the things I just talked about?
Yeah, I think statistically, your statistics are kind of right on. It is one of the most common reasons for someone to seek medical attention, and we certainly see a lot of it in our practice. You know, and whether it's purely muscular or coming from somewhere else, kind of the things that I usually tell people to look out for initially when they start having this back pain is, was there a specific thing that happened when it started? Do you remember, like, oh, I was lifting a heavy box during a move or something, and that's when this started? Was I out gardening? Was I playing tennis or golf, and all of a sudden on one swing, that's when things kind of set in? Or was this something that happened more gradual and it's been going on a long time? And there kind of can be two different entities and reasons for it, but certainly there are a plethora of reasons for back pain, and I think we'll go through kind of a lot of that. But I would say, you know, the best place to start when you have any of those kind of symptoms are with myself or with physical therapy, because certainly anyone who comes to me with low back pain, I would say the majority of low back pain, probably 90 to 95%, the treatment is going to be physical therapy and, you know, core strengthening and flexibility. And those are really going to be your keys. And it's more what these guys can do for you than what I can do. Certainly there are medications that we use, and we'll talk a little bit about that. But certainly, you know, being in the hands of a good physical therapist is the kind of the starting place.
Yeah. One thing I wanted to ask you, Dr. Harris, is when people come to your specific clinic for low back pain, what things are you kind of looking at as, you know, red, yellow flags, you know, like how can you help them in a plan of care? Because I've heard some PTs talk about it, you know, we want to keep basically non-specific low back pain and things along those lines out of the medical system as best as we can, just because we know with, you know, certain pharmacological treatments and stuff like that, it tends to not be, you know, the more we're involved with that, theoretically the worse outcomes technically or can be. Yeah, I just wanted to hear your thoughts on those comments.
Yeah, I think when you have low back pain and a reason to come and see me, things that you really want to be watching for, like I said, was there a specific incident when it started? Is this more of a gradual thing that's kind of been going on for some time now? Is it getting worse over time? Have you been doing stretches and exercises and you're not making improvement, or you've been doing them and things are actually getting worse? Numbness and tingling. Where at a lot of times with the low back pain and that radiating pain, you'll have pain going down the legs, but maybe not necessarily the numbness or the tingling. So if you're having those symptoms, kind of keeping a mental note of where that is it going down the side of the leg? Is it stopping before it gets to your knee? Is it going below the knee? Because that's going to give us a better idea of where the nerve impingement or where the issue is coming from, how high up the line, how up the chain it's coming from. So paying attention to those kinds of things. And then is there any loss of strength? Are you noticing weakness in that leg that's been affected? Having any difficulty with walking or, with, strength things. If you were, lifting or golfing or playing tennis and you're just noticing like, man, I just really cannot do things with my one leg like I used to be able to do, or fatigue's much easier than my other leg for some reason. And then another concerning symptom would certainly be if you notice actual muscle loss. So you're looking at both legs and you see like, wow, my quadricep on one side is getting smaller than the other side. That's certainly a red flag and a reason to get in to see your doctor sooner, because that might suggest that your disease is more progressed, and the earlier that we can intervene, the better off we're going to be. Red flags that you really want to watch out for: loss of bowel or bladder control. Those are concerning symptoms that need to be dealt with emergently. Sudden or non-purposeful weight loss. So, over a month or 2 months or 6 months, even, you have this weight loss and you really haven't changed anything in your diet or your exercise program, and all of a sudden you're noticing this weight loss. Or certain things like fevers and night sweats. Those are big red flags for us. And then, other reasons to come and see me, like I said, stretches, exercises, you've been doing them, trying your over-the-counter medications, and things just are not getting better for whatever reason. That's, a good reason to go see your sports medicine doctor.
Yeah, I could have said it better myself, and I had kind of a list of red flags of things I wanted to talk about too, and you nailed everything that I was going to say. So we typically see in the clinic sciatica kind of going more as a unilateral leg condition. We don't see it too much as a bilateral leg condition. If that's the case, there could be potential causes for a referral out to you, Dr. Harris, because typically the way sciatica or some sort of radiculopathy manifests, it's usually on one side, where if it's on both sides, you always clearly want to look at the spine and things along those lines. Yep. We've talked a lot about acute pain, where people are playing golf or swimming or something and kind of throw out their low back. I mean, I think if we wanted to dive into chronic pain, there would be a whole nother podcast or video for this, because there's a lot of other variables involved with that. But yeah, I thought you hit that like on the head, and that was really cool to hear your thoughts on that too. With the things that you mentioned with the red flags, do you believe there's those are the times when you should get imaging compared to other times?
Yeah, certainly. I mean, there's, pretty good evidence that suggests the majority of low back pain does not require imaging. So the majority of people don't need them. I think there's a little bit of an expectation when you go to a specialist that you're going to get imaging. So there's a little bit of that to deal with. But for the most part, a good physician can kind of tease out where, that pain is coming from, or if there are any of those red flag symptoms, certainly imaging is going to be warranted. And, the place I start with my imaging is going to be with, an X-ray. And, we also have ultrasound in our practice. So I will do, ultrasound depending on where the issue is, if it's more coming from the leg, or sometimes, back pain is masquerading as more as actually a hip pain, or like a greater trochanteric bursitis on the side of the leg. Certainly using the ultrasound in the office can be helpful for those things. But my starting point usually for people, especially if they have any of those symptoms, is going to be an X-ray followed by an MRI. Now, the X-ray is going to show us any kind of bony pathology. And certainly if there are those red flag symptoms, I'm looking for things like pathologic fractures, or, tumors or things, if there's been weight loss or the fevers and night sweats, and those kind of things. And the X-ray will a lot of times be able to help me with those things. I can also see some disc height loss, where there might be potential for what we call spondylosis or degenerative changes. And truth be told, anyone who comes in and gets a back X-ray, there's going to be some level or some degree of degenerative changes. So that's not abnormal in and of itself. And usually the X-ray is just kind of a way to rule out really bad stuff, kind of a very, a way to just look at things and say, okay, I don't see anything obviously bad here. And then it's going to be, doing your 4 to 6 weeks of physical therapy. And over that time, I would expect to see some pretty good improvements. Now, when there's not, then next up would be the MRI. And the MRI obviously is going to show us, if you're having those neurologic symptoms going down the leg, or, muscle wasting or loss of strength or loss of reflexes in that leg, we'll be able to see where that impingement is happening, whether it's a slipped disc or a ruptured disc in the back, or if there's degenerative changes that have taken effect, so much so that there's pinching off of those nerve roots as they exit the spine, or maybe it's coming down lower from a muscular thing where the sciatic nerve actually travels under the piriformis muscle. Sometimes there's variables in people's anatomy where that nerve actually pierces the piriformis or comes out above it, and just structurally that causes issues for them. And maybe it's more something like that. But certainly those kind of things we'll be able to see on the MRI. And that's, again, usually something that comes after doing the physical therapy, where it's like, hey, we're just not making progress, not getting better. And why is that? And usually I'm reserving my MRIs for people I'm thinking are going to need some kind of back injection or are going to need some kind of surgical planning.
Mm-hmm. And those are people who basically have failed conservative treatment for the most part.
Exactly.
Yeah.
Yep.
Ryan, anything you want to comment on?
Yeah, Dr. Harris, what percent of patients coming to you with sciatica would you say are you doing ultrasound guided injections? I know that's not your first go-to, of course, but I'm curious to hear what the approximate percentage of that might be.
I mean, I would say it's probably somewhere like 5 to 10% would end up actually going on to require some kind of injection. And certainly, we see people who do really, really well with conservative treatment for a long period of time. I mean, years and years, even before things progress to a point where they actually need some kind of, intervention with an injection of some kind. More often, I would say the ultrasound guided injections that I end up doing are when they think this pain is coming from their back and actually they have really bad hip arthritis, and that's the generator of their pain, or they have a greater trochanteric bursitis with some glute medial tendinopathy or a chronic tendinopathy kind of on the outside of the hip that they think is actually coming from their back, but it's really more isolated to that area. So I personally don't do spinal injections, but certainly when people require them or would benefit from them, we send them to a pain management or a physical medicine and rehabilitation doctor who do those types of injections under fluoroscopy or a form of X-ray.
Okay. Yeah, go ahead, Brady.
For the viewers watching, for those who do have sciatic or have had sciatic in the past, typically those symptoms that are distal to the knee or worsening or going lower into the leg, or it's called like peripheralization, those tend to be, more, the symptoms are getting a little bit more irritable and a little bit more worse compared to symptoms actually traveling up the leg and into the spine. That's called a phenomenon called centralization. That's typically what you want to feel during any sort of rehab, or even I'd imagine with some sort of injection too, is you don't want symptoms further down into the leg and intensifying. We always want to make sure symptoms are getting up closer to the spine. So when we're doing treatment in here, or with Dr. Harris and with his specific interventions, I know sometimes if we can get rid of low back or get rid of leg pain while the low back gets a little bit more uncomfortable, I will take that all day.
Yeah. You say similar to what I was going to say. So what I'll say right now is that I forgot to mention in the beginning, if you do have a question as you're going here, there's the chat option on the side. So please feel free to leave a question for any of us. We're happy to answer it, and we'd like to make this as interactive as possible. So if you have sciatica and you're wondering, this or that about your particular condition, please leave it in the chat box, and we'll answer all those questions throughout. Brady, we talked about some treatment options, and Dr. Harris had a chance to cover what he is doing in his practice. Let's see what types of exercises some of these individuals who are watching can do if they have sciatica-like pain, and they can start trying these and see how they feel.
Okay. So I'll first start off with kind of like the end goal of what we believe here at Flash of what end treatment should look like. I'm a huge proponent of getting people out of pain and then trying to get them as fit and as strong as possible. I believe really the only good research out there to kind of predict your future risk of injury is basically how strong you are. The stronger you are, the least likely you are to get injured, but there is no direct correlation. You always have a chance of getting injured with anything you do. At the end of any treatment session we have, a plan of care, we always want to make sure our patients' low backs are as strong as they can be. We try to always incorporate some sort of deadlift variation into their plan of care, get their lumbar paraspinals nice and strong, as well as knowing how to squat correctly, because we just believe that strength goes a long way here at Flash. But before we get there, we obviously have to make sure from a symptom provocation standpoint, our patients are doing well. Their symptoms are centralizing with sciatica. There's a good, we do use, even I think the AMA has said this recently in a recent systematic review or something along those lines, that the best forms of treatment for nonspecific low back pain include acupuncture, spinal manipulation, and exercise. So that's what we try to. We don't use acupuncture. We do dry needling in our clinic, but it's similar. We want to always make sure with sciatica symptoms, we are centralizing symptoms towards the low back. We want to restore motion as much as we can. Typically with those type of symptoms, clients are very restricted in one plane of motion with the spine. We try to find what motion that is and trying to figure out how to centralize symptoms. Most of the time, people are pretty resistant to going into some sort of low back extension because it is painful. A lot of times you want to work in that position though, because it does centralize symptoms. Like I said, it's hard to give a cookbook approach here because it does take a pretty good evaluation to figure out what exactly movements are best for you. But at the end of the day, we have someone here at the door. Can you hold on a second? Can you finish that thought?
Sure. Yeah, go ahead. Anyway, Dr. Ray was talking about there's no cookbook approach, and Dr. Harris and I also agree with that you really need to, one, determine what's going on. Is it sciatica? Is it a low back issue? Is it something else? And then what particular set of exercises and other types of treatment would you most benefit from? However, there are some exercises that seem to hold true for most who have sciatica, and what could a lot of people benefit from. So what we would recommend today is that if you are, having, these types of problems, to at least try out one or two of these exercises and see if it does influence your pain, whether it increases, decreases it, and try it out. And if you don't, in any case, if it's something that has been bothering you for a long time, Dr. Harris is the guy to go and see and have him check you out and let you know what is going on so that you can get back to feeling great on the golf course and the tennis courts.
So I'm back. I caught the first part. There was a telemarketer at the door. I had to make sure to shoo him away real quick. I told him to come back in a half hour.
Yeah, I hope you.
So anytime we're doing any sort of exercise, we want to make sure with radicular symptoms, sciatica symptoms, like I said, we want to centralize symptoms. I'm going to go over a couple basic things. And like I said, there's progressions and regressions of each of these exercises. And if done appropriately, I'm a firm believer that these repetitive motions can get the job done, at least minimize pain and get you to a point where you're deadlifting, getting stronger, getting the low back stronger, things along those lines. I have a table here. I'm going to do a classic press up exercise. And then I'll add in what's called a Jefferson curl, a really, really good low back stretching exercise into flexion, which I kind of, for those who respond well to extension, I kind of go more into flexion afterwards. Once symptoms are centralized and start going into more flexion to restore all ranges of motion to the spine. You want to make sure by the time clients, yourself, when you guys are leaving, you want full range of motion of all symptoms in your low back without pain. That's the ultimate goal. Then boom, it's all about strength after that. So I'll see if I can set up my table here. So you guys can try this at home. Like I said, the number one goal is for symptoms to not go down the leg or intensify down the leg. We kind of want things to go up towards the glute and towards the low back. Ryan, can we see myself here pretty good? For the table?
Yeah, once you get on the table, it should be all right. If you can angle it down, there you go.
My computer may get in the way here, but all right. So I'm going to
Fine. Yeah.
classic press up exercise. For those who have sciatica, at some point, I do like to incorporate this into your home exercise program. Okay. So what we're doing here, I like to start, if it's really bad, just laying on your stomach and just getting a little bit of a lumbar extension, getting used to that. Then we kind of go up onto our elbows here, or hands in front of your head here, kind of far out. Lock out the elbows, exhale, make sure you let the glutes relax, hang out for 4 to 5 seconds. We try when we can, hands under the shoulders and do the same thing. Lock out the arms, exhale like so, and let the glutes relax. A lot of people will tend to really squeeze their glutes to promote a little bit more of low back flexion. You just want to make sure that low back is extending as much as you can. You want to get to the end range. Good research. There's very good research to show the reason why repetitive motions are so effective is because it does a good job at hydrating the disc to some extent. There's a direct correlation with disc hydration, post-rehab exercise, and pain from what the research shows that I see. So those press-ups are a really, really good exercise. Like I said, they may not be ready. You may not be ready for those at that given time, or you may be able to progress to something else. But a lot of people respond well to extension. We want to always get those symptoms into the back and get them out of the leg as quickly as we can. Another one, which I have personally fell in love with the past couple of years, is what's called a Jefferson curl. This is kind of more late stage rehab, but for those who have more non-specific low back pain, who are tight throughout the posterior chain, the glutes, the hamstrings, low back, possibly some neural tension. I like to pick anywhere between like a 15 to a 20, 25 pound weight. This and use it almost as an anchor to promote as much low back flexion as we can when we can tolerate those symptoms. Okay, so I stand on a block about 1 foot high here. I don't know if you can see that. I'm basically taking this weight. I'm promoting as much spinal flexion as I can here, starting with my head, going all the way down. And we're just letting this weight just drag our whole body down towards the ground. Right now, my hands, you probably can't see, are even with my toes. This weight acts as like an anchor to just promote some more low back flexion there. I have found particularly those with non-specific low back pain who are maybe a little flexion intolerant, very, very good exercise. I'll demonstrate again, nice and tall. Start with the head, down into the spine, low back, down like so, okay? And just hang out 3 to 4 seconds. And then repeat. I'll do that anywhere between 6 to 8 times total for a couple sets, depending on what the patient can tolerate. But at the end of the day, the number one thing we always want to get our patients doing is making sure their strength and their obviously their fitness and their cardiovascular system are in a good place. So these are all kind of things to reduce pain. But then once that's settled down, we can start working on strength as best as we can. When I'm talking about strength, ideally, free weights is a good way to go. We want to make sure that we're working at a relatively higher load that you can tolerate. We do know that we want to stay typically, above your 60% 1RM. I know we can't really, determine that most of the time in the clinic, but we do want to go rather heavier than lighter because we want to hit that strength threshold to actually promote some changes in low back hypertrophy and strength, which also drives down pain.
Yeah, and the other thing that we like to add in, although we wouldn't recommend you go and do this on your own right now, is something called nerve glides. So you can stretch a nerve just like you can stretch a muscle. And like Dr. Harris was speaking of earlier, different spots where the sciatic nerve can become entrapped or impinged. You can target certain areas of your leg coming, so from the spine down where the nerves exit the spine and go down the back of your leg the whole way, which is the sciatic nerve, and it splits, a little bit lower down for anyone who knows their anatomy besides us. But you can target this nerve and stretch in different ways, and this can drastically reduce symptoms. So whether you have pain down the leg and low back pain, or just pain down the leg, and you've been seeing someone, they've been only working your low back, with working with the PT, like us who knows how to evaluate that, and being able to add this nerve stretching into your program is extremely helpful. Dr. Harris, have you seen those utilized successfully yourself by PTs or others in your practice?
Yeah, absolutely. Like I said, I think, one of the biggest things with low back pain, generally speaking, for the majority of people is getting them in the hands of a good physical therapist. And, things like the stretching, the nerve glides, and the strengthening are really the hallmark and key to getting this pain better. There are medications and things that can be used to help with inflammation that I can prescribe, but ultimately that's only a temporary fix. And the way to really get long-term relief with these things is the core strengthening and the stretching and the flexibility program that a good physical therapist can put you on.
Yeah, absolutely. And yeah, so we see very eye to eye on these things, because both Dr. Harris, Dr. Brady, and myself are looking at how can we address your symptoms, but what's the root cause, and how can we eliminate this for you in the long term? It's not a matter of popping some Advil, which so many golfers and tennis players and other active people do constantly. And what things can we do to make sure that you don't have this pain in the long run? So we share a very similar philosophy with that, and that's why as their practice is opened, we're excited to continue working with you all. Dr. Brady, any other comments that you wanted to add? And we'll start to open it up for questions too. I'll be watching both Facebook and Zoom here if anyone watching has a question as we go. But anything else you'd like to add as we start to close up here?
Yeah, Dr. Harris, I was curious if you have any particular niche or patient population that you work with a lot. I'm wondering gymnasts or anything along those lines that come to see you directly.
Certainly happy to see gymnasts. My business partner and co-founder, Dr. Beatty, is a former gymnast and diver in college as well. I obviously did gymnastics my entire life. I would say the majority of the athletes that I see, just because they're more, prominent, prevalent sports in the area are football and soccer, lacrosse, certainly a lot of baseball pitchers, but we really see any and all sports. I would say my favorite population to work with is really anybody who just has a willingness to maintain a level of activity in their life. And really the goal for Dr. Beatty and myself is to keep you at that level of activity and do what we can to keep you doing the sports you love, whether you're 8 years old or 98 years old. So, any and all people who want to be active, we're certainly happy to work with you and help you in any way that we can.
And what would treatment from you look like? How does a plan of care kind of evolve? I'm curious. I don't know myself how that would work.
Yeah, in terms of for specifically for sciatica or back pain like this, I would say the majority of people who come in, I obviously will do a full evaluation and sort of tease out where that nerve entrapment or impingement is coming from, rule out any kind of red flag symptoms or causes. And then a lot of times I'll order the x-ray, and I may say, go ahead and get this, or even, get started with physical therapy. And if things are not, progressing as quickly as we hope, then maybe get the x-ray. And that way, when you come back and see me in a couple of weeks, if we're still not progressing, we can get the MRI, because a lot of insurance companies will require that x-ray before getting an MRI. So we're sort of a couple of steps ahead of the game. In terms of medications, I certainly prescribe, a lot of anti-inflammatories for these things. I think the key with that is that it's not a long-term thing. So sort of short bursts of these medicines, I think, are helpful, especially getting started in PT. If you're really in so much pain that you can't do the things that you need to do in physical therapy to make the gains that you need to make, sometimes something like a prednisone can help to sort of calm down that inflammation and allow you to do more in the physical therapy so that you can progress a little bit faster. But like I said, I like to see people back then after 4 to 6 weeks of doing their rehab program to make sure that things are progressing and they're going in the right direction. And then if they're not, we pivot, and that's when we go to our, further imaging steps, or, we look for other causes of what may be going on.
Yeah, I think personally that's a great way to go about it. I think that's where all medicine needs to basically to come from with that aspect. I admire you guys. I wanted to say this. I admire you guys for kind of going off the beaten track and opening up your own business and trying to treat people authentically, because personally, I'm not against big hospitals, but I tend to think more the private practice sector, people tend to get better results and get better care that way.
Yeah, it's easy to get lost in the larger machines, and certainly we wanted to make sure that we're treating people the way that they should be treated, and making sure that everyone gets the type of evaluation and treatment that they should be getting, and doesn't feel like something on a conveyor belt that's just getting passed along to another person. So yeah, thanks, I appreciate that.
Yeah, it's a big problem in medicine, the PT world right now as healthcare evolves, but with independent practices like Beatty Harris Sports Medicine and Flash Momentum, that's really the key to helping a lot of active people out there find solutions that they wouldn't be able to find elsewhere. So we're excited to be working with you here, have you on for the Zoom today. It was awesome. And I didn't notice it before, but I like your Penn State poll, by the way. Very fitting.
That's
and,
right.
A nice touch for today. So
well, I appreciate you guys putting this together and for having me.
Yeah, absolutely. We'll have to do another time too. It looks like we don't have any questions on the Zoom. If there's anyone who's watching now or watching this later and would like the replay, email Brady@flashmomentum.com. We'll shoot you a copy of the replay. You could also find it on our Facebook channel, Flash Momentum, where it'll be pretty much the top, and you can watch this straight through if you want to review the exercises again or listen to something that Dr. Harris had to say, or Dr. Brady or myself. Dr. Harris, what, we talked about, and you talked about at length, what, when someone should go and see some sports med doc like yourself, how's the best way for anyone who's watching this now or later to reach out to you to schedule an appointment if they'd like to have their sciatica evaluated?
Yeah, so probably the easiest way is to go on our website. It's www.beattyharrissportsmed.com, and it's BEATTYHARRIS sportsmed.com. You can put your information in right on the site, and we'll give you a call to get you scheduled. Can also call us at the office, 610-601-9177. And certainly through these guys, going and working with them, if they feel, through working with you that you'd benefit from a little bit further evaluation by one of us, we'd be happy to see that way as well.
Yeah, absolutely. Anyone who is not making the progress that we know that they can make with more help, we're sending, over your way, and that's what we do, because Brady and I have a firm belief that someone's not making progress, and you gotta change course. You can't have them continue to push through when you're not doing the things that are going to help them most. And a lot of people make great progress with what we do, but sometimes you need a further evaluation or to change it up a little. So getting an opinion from you if they haven't seen you already is always beneficial. So we really appreciate you joining us today. If you'd like to find out more about what we do as sports PTs at Flash Momentum, you can Google Flash Momentum or go to www.flashmomentum.com. We're happy to work with you on anything from an injury, a strength and conditioning program, or anything else regarding video analysis of your sport and your technique. So this is a lot of fun today, and we hope everyone has a great rest of the day, and we'll look forward to seeing you all soon. Thanks, Dr. Harris, for joining us.
Yep. Thanks, guys.
All right,
Stay safe.
see you.
Thank you. Take care.